Professor Josef Neu. He's the director of the Neonatology Fellowship Program in Wisconsin University. And he's going to give 2 lectures through a teleconference, a sort of simulation. One of them is on the motility issues in the developing GIT. The other one is early, transitional, and post-discharge enteral nutrition. So let's listen to him.
Yes, hello.
Yeah. Hello.
Yes, dear Professor Joe, can you hear me?
I can hear you, yes.
Okay. It's a great pleasure having you among us in our third International Neonatology Conference. Actually, we have with us eminent speakers, Dr. Julian Eason from UK and Dubai, Dr. Ibrahim El-Balawi from Saudi Arabia, and Dr. Craig Smallwood from Boston, USA. Of course, we were expecting you with us, but actually this will add a lot of knowledge to us. Do you want to say anything before the lecture?
Nothing special other than it's a real pleasure to be here, and I'm sorry that I could not make it personally to Cairo, but there were some circumstances that just did not allow me to do it. So I'm glad that I could at least be with you electronically and remotely as we are right now.
Actually, the window in which the slides are apparent on the left side is not complete. Yesterday it was complete. There's a problem in the screen in your laptop. Can you fix it, please?
Okay. So there's something in the screen in the laptop?
Yeah, I can see 2/3 of the slides. The other third not apparent.
Let's see. What if I do this? Oh, okay. Is it better?
No, the same.
Is that better?
No, it's the same. We can try.
Can you see the slides changing?
Actually, most of the slide is apparent, but not all of it.
Not all of the slide is apparent. We're here. Okay. Yeah. Okay. Does that help any?
Yeah, this is perfect. Okay.
Okay, that works now?
Yes, it's great.
Okay. Very good. Would you like me to start?
Yes, of course.
Okay. So, here. Okay. Okay, so I'm going to just make sure that the presentation moves forward. You see it moving forward?
Yes, we can see you. And the presentation
okay,
also.
Terrific. Okay, thank you. Thank you. So it's a great pleasure for me to be here, and Dr. Gada asked me to speak about the motility issues in the developing gastrointestinal tract and also some issues on nutrition. So we'll have 2 lectures today. It is morning here in Florida, and I guess it's 2 o'clock in the afternoon there in Cairo right now. So I'd like to start with this concept that the intestine is really more than a digestive absorptive organ. It's also the largest immune organ of the body. It harbors a huge microbial ecosystem which we're just beginning to recognize is extremely important for our health and well-being, and it's also a major neuroendocrine system. What I'd like to do over the next 45 minutes in this lecture is talk a little bit about intestinal growth and in utero physiology, some motility issues such as suck, swallow, and breathe coordination, then talk about gastroesophageal reflux and gastroesophageal reflux disease, then about gastric emptying, and a little bit about intestinal and colonic motility and the clinical implications of the developmental processes that we see with these motility issues. So let's just start out with growth of the intestine in the human fetus. It elongates about 1,000-fold from 5 to 40 weeks gestation. The length doubles in the last 15 weeks of gestation, and the mean length of the intestine at birth in a term infant is 275 centimeters. But this is just the tip of the iceberg when we think about the entire size of the intestine and the surface area of the intestine. We also have villi, and on top of these villi we have intestinal epithelial cells, and with these intestinal epithelial cells in the apical surface we have microvilli. And with a combination of these villi and microvilli, we have a tremendous surface area that is approximately 200 square meters, about the size of a tennis court in the adult human. And when we look at the entire surface area of the skin in the adult human, it is only 1.6 square meters. So this is a huge surface area that we see in the intestine in humans. Now, in the fetus, the intestine is not inert. It is a very active organ. There are many developmental aspects that are occurring during fetal life in terms of the intestine. We have recognized that the fetus swallows large quantities of amniotic fluid. So in the third trimester, approximately 150 milliliters per kilo of amniotic fluid are swallowed during this third trimester. That accounts for approximately 450 milliliters per day, close to the end of the last trimester. And when the baby is born prematurely, this is suddenly interrupted at the time of preterm birth. So at that time, the newborn preterm baby usually does not get such large quantities of fluid shortly after birth. But this concept does let us realize that the fetus has the capability to swallow large quantities of amniotic fluid and to process this amniotic fluid through the gastrointestinal tract in the third trimester of pregnancy. When the baby is born prematurely, we have several mechanical difficulties that relate to motility of the gastrointestinal tract. For example, there's suck, swallow, and coordination, which necessitates tube feeding. And this is usually seen in babies that are born less than approximately 34 weeks gestational age. We have a problem with gastroesophageal reflux.
Sorry, we cannot hear you.
Approximately 2 to 5 days in the preterm infant, whereas in the term infant, it's 24 hours and sometimes even less. So let's start from the top of the gastrointestinal tract and sucking, the sucking response. In babies, there are two types of sucking that we see, two major types. One is called nutritive sucking, and this is 1 suck per second.
Sorry, Professor Neu, we have a problem. I don't know if you hear me.
Esophageal function
Sorry.
and respiration.
Sorry.
So we have to have a suck, a swallow, a breath, and the
Excuse me.
esophageal function occurring.
Excuse me,
And
Professor
along
Neu.
with this, we also have,
Excuse me, Professor.
Yes?
We had 2 times total loss of your voice. For 2 times. I think we need assistance. The
okay,
voice
can you
was-
hear me now?
Yes, I can hear you now, but it occurred twice. For example, 15 seconds, we don't hear you at all.
Okay. I'm trying to use my, I'm sorry?
Can we again the previous slide, please? The 2 previous slides.
The previous slide. Yes.
Yes. The previous
Okay.
one also, 2 previous slides. Yeah, this one. Since this one,
Yes.
we started not.
Yes. Yes. And so these are some of the mechanical difficulties that we see in the preterm baby, which includes suck, swallow, and coordination. And this may necessitate tube feeding. We have some problems with, but this can be a normal physiologic process, but this normal physiologic process in some babies may actually lead to problems, disease problems, which I'll talk about shortly. We have a difficulty where gastric emptying may be delayed. Intestinal motility is disorganized in preterm babies, and the gastroanal transit in extremely low birth weight babies is much longer than in term babies. In extremely low birth weight babies, it may take 2 to 5 days for food to enter the mouth and finally be excreted through the anus, and in term infants, it's usually 24 hours or less. We have 2 major forms of sucking that occurs in babies. One is called nutritive sucking, and this is 1 suck per second, and this is accompanied with active swallowing. We also have non-nutritive sucking, where there are 2 sucks per second, but there is minimal swallowing. Non-nutritive sucking is sometimes called practice eating. So here we have 2 diagrams. On the left, we have nutritive sucking, and on the right, we have non-nutritive sucking. And with the nutritive sucking mechanism, we see feedback loops. And these are closely interconnected. They are dependent on one another. You have a suck, which is followed by swallowing, which is followed by respiration and esophageal function. But these also provide feedback loops so that this does not go totally in a chaotic fashion. With non-nutritive sucking, there are no feedback loops, and so this is much more of a chaotic activity. Here we see the development of nutritive sucking. On the top, we see very premature babies, and on the bottom, we see babies closer to term, more full-term babies. And here we see suction, expression, that's when the milk gets into the mouth. This is time, suction, expression. And here we see that in the very preterm baby, there's almost no suction, but a small amount of expression. But in the term baby, we have good suction, and that is coordinated really well with expression. And here are all the steps in between. So it takes time for this process to develop. Readiness to oral feed is a primary concern of caregivers before weaning patients from tube feeding. And the current practice includes actually trial and error. Usually this begins to occur between 32 and 34 weeks post-menstrual age. We have problems right now with this because we don't have any technologies that actually are able to help us. So again, this is a trial and error kind of a situation, and there may be some measures such as sideline feeding position, cheek and chin support and cue-based feedings that might be helpful. And it's really important to establish oral feeding because this is often an important criteria for hospital discharge. And I know that at least in our hospital, and I'm sure in many other hospitals, this is a factor that sometimes keeps babies in the hospital much longer than what we would like to see them stay in the hospital. So this is an important component for hospital discharge. Now, what about gastroesophageal reflux and gastroesophageal reflux disease? Well, gastroesophageal reflux is actually a physiologic event which involves retrograde movement of gastric contents into the esophagus. And this can be important because it equilibrates pressure from the stomach into the esophagus. And this can be a very normal and a good mechanism. However, if you have gastroesophageal reflux disease occurring, this is a pathologic entity that includes complications that are derived from gastroesophageal reflux. So here is the normal pattern that we see where you have changes in pressure in the different regions of the pharynx, esophagus, and associated sphincters that are initiated during the swallow reflex. These are mediated by cranial nerves 9 and 10, and then the swallow reflex and closing of the lower esophageal sphincter is accompanied by excretion of a hormone called vasoactive intestinal peptide, very important hormone in this process. What are some of the gastroesophageal reflux disease symptoms that we might see in our premature babies? Well, this is not a preterm baby, but this is a baby that is showing regurgitation. You may have a Sandifer type of posturing, which means leaning backward and arching of the back. You may see aspirated refluxate that injures the lungs, and this can exacerbate chronic lung disease or bronchopulmonary dysplasia. You can have food refusal or intolerance that occurs because of this. But it's important to remember that most babies who have gastroesophageal reflux are what we call happy spitters. That is, they may have some regurgitation, but overall they are growing well, they are healthy, and they will eventually outgrow this regurgitation problem. But one of the biggest concerns that we have had in neonatology is apnea and bradycardia in preterms and the relationship of apnea and bradycardia to gastroesophageal reflux. Now here's a case, very preterm baby, and the nurse reports to you that this baby is having lots of apneic and bradycardic episodes and is convinced that these episodes are being caused by reflux. Now the question do we have, is this true that most of these babies who have apnea and bradycardia might have reflux that is causing of preterm infants in U.S. academic centers were treated with a drug called cisapride. What was the purpose of the cisapride? Well, cisapride is a drug which is a pro-motility agent. And the concept at that time was that poor motility caused gastroesophageal reflux, and gastroesophageal reflux caused apnea and bradycardia. And we see many of our years ago,
sorry,
and therefore it was thought that gastroesophageal reflux disease
Professor Neu,
must be a common...
Excuse me.
Yes.
We had the same problem again. Your voice was totally lost for the last slide. I don't know, is it a problem of internet? I mean, if we, for example, remove the photo, we can have a better connection or not? If we can switch off the camera, maybe? I don't know.
I just unmuted again just to make sure. Can you hear me now?
Yes, I can hear you.
Is it clear?
Yes, it's clear, but it stops abruptly for 2 times.
Yeah, I am not sure what I can do about that.
Is it better to convert it as a voice call instead of video call, or we will lose the slides?
Well, I think we should continue with the slides, don't you?
Yeah, of course.
Maybe I could turn off the webcam. Maybe that would help.
Maybe, yeah, we can try this.
Not that okay. How's that? Okay. Can you hear me okay?
Yeah, we can hear you and we can see the slides. Okay, we can try this. Thank you.
All right. So these are some of the references that showed that gastroesophageal reflux, or suggested that gastroesophageal reflux disease must be a common problem in the neonatal intensive care unit. And again, the reason for this concept was because preterm babies exhibit a lot of apnea, and there is also gastroesophageal reflux in these babies. So the question then are these clinical signs in babies reliable in the diagnosis of gastroesophageal reflux? And are apnea and bradycardia actually causally associated with gastroesophageal reflux? So let's start with this study that was published from Australia in 2000 by Snell and colleagues. And they asked the question, are clinical signs, behavioral signs, reliable for gastroesophageal reflux disease in preterm infants? What was done in this study was they took films of the infants and then showed them to different observers, nurses, doctors, and they found that there was a 74% inter-observer agreement in episodes of coughing, hiccuping, gagging, and head retractions, etc., all of which are signs that would be considered to be consistent with gastroesophageal reflux. They also had a tube in the esophagus to monitor pH, and they found 20 episodes of acid gastroesophageal reflux in these studies with a pH of less than 4, but there was no behavioral pattern that was temporally correlated with acid reflux. These symptoms that they were seeing on these films of these babies did not match with the acid reflux episodes. Here's another study that was done at Case Western in Ohio. And the question that was asked in this study is, does gastroesophageal reflux cause apnea and bradycardia in preterm infants? In this study, they not only used a pH probe, they also used multiple channel impedance monitoring, which measures pressure in the esophagus. So not just acid, but pressure changes in the esophagus, which are related to reflux. And they did these studies in 71 preterm infants with a mean gestational age of 29 weeks. And they studied them at a post-menstrual age of 37 weeks. They evaluated the timing of gastroesophageal reflux events versus apnea and bradycardia. Here we see all events, apnea, bradycardia, and desaturation episodes, and only about 3% of cardiorespiratory events were preceded by gastroesophageal reflux. In fact, they found more gastroesophageal reflux events that were preceded by apnea than the other way around. So what does this tell us? This tells us that gastroesophageal reflux is not associated with the vast majority of episodes of apnea in preterm infants. In a very small number of infants, about 3%, there is a relationship between gastroesophageal reflux and apnea, and there are some preterm, former preterm and term infants in whom gastroesophageal reflux may be a contributory factor for precipitating episodes of mixed or obstructive apnea. Most of the babies will outgrow these episodes within the first months of life. Whenever we do studies looking at gastroesophageal reflux and apneic episodes, we have to take into account that these babies are also undergoing maturational changes, and thus one needs to consider doing crossover types of studies. Here is an example of a crossover type of study that was done at University of Texas, and this is a crossover trial of preterm infants where they received metoclopramide and ranitidine, and they evaluated episodes of bradycardia per day during drug periods and during placebo periods. So again, this was a crossover trial. And what they found was that during the drug periods, when they were receiving the metoclopramide and the ranitidine, they actually had more bradycardia than if they were receiving the placebo. And this again suggested that the bradycardic episodes were not being caused by by reflux that could be potentially ameliorated by these drugs, and that these drugs actually caused more bradycardia episodes per day than the placebo. So what can we do if we're concerned about babies having problems with gastroesophageal reflux? Well, there are some fairly simple things that can be done. One of them is just simply positioning the babies. This is a study that was done in Italy by Corbaglia and colleagues, and what they found in this study was that the left side down position showed the lowest esophageal acid exposure in the early postprandial period, and the prone position showed the lowest esophageal acid exposure in the late postprandial period. Sudden infant death syndrome. But here, when we consider babies that are preterm and in a neonatal intensive care unit who are being monitored, that would be a different story. About 2 years ago, a paper came out in the journal Pediatrics, and the title of this paper was Choosing Wisely in Newborn Medicine. We want to avoid routine use of these medications. A couple of years ago, it was reported that there were several infants that received thickeners. And this particular thickener, called Simply Thick, was on the market, and it was being used for putative relief of gastroesophageal reflux disease in preterm infants, mainly babies who were having apneas and bradycardias. So these babies started this preparation in the hospital and then were sent home on this same preparation. This is a thickener for formulas. And it was found that many of these babies developed late onset necrotizing enterocolitis at home following the use of this agent. This agent has recently, there's a warning label that this agent should not be used for preterm babies who might be at risk for the development of necrotizing enterocolitis. So what are some of the diagnostic tests that we can use to evaluate gastroesophageal reflux disease? Here are the tests. Here are some of their strengths and weaknesses and ability to quantify gastroesophageal reflux frequency and ability to diagnose gastroesophageal reflux disease. So here we have the upper GI series. And the strength is that it can identify mimics of gastroesophageal reflux disease, such as obstruction. But its weakness is that it's very brief. You can only get a snapshot over a very small period of time. And you also have a lot of radiation exposure given to these babies. You are not able to quantify gastroesophageal reflux frequency. And you are also not truly able to diagnose gastroesophageal reflux disease because you have to have correlation with symptoms. Here we have esophageal pH and multi-channel intraluminal impedance. So this measures acid, this measures pressure inside the esophagus. And these are studies that are done over time, usually 12 to 24 hours. And they can't allow for quantification. But the problem with the multi-channel intraluminal impedance, you don't detect the acid. And for the esophageal pH, we really don't know if it's just the acid or non-acid triggering of some of these events that might be causing problems in the babies. We are able, with these two studies, to quantify gastroesophageal reflux frequency. But are we able to diagnose gastroesophageal reflux disease? No. We can only diagnose gastroesophageal reflux. You have to have correlation with symptoms for these two diagnostic tests. What are some of the pharmacologic therapies that are being used? And again, I think that it's very important to remember, none of these should be used routinely in preterm infants for problems such as apnea and bradycardia. Here we have the H2 receptor antagonists. They suppress acid production, and the proposed benefit is the suppression of gastric acidity and mitigation of tissue damage that triggers pain. We also have adverse effects from the H2 receptor antagonists. And I think it's now very clear that you have more necrotizing enterocolitis, late onset sepsis, respiratory infections, and death related to the use of these H2 receptor antagonists. There's also an association with increased IVH, bradycardia, and decreased calcium absorption. PPIs suppress gastric acidity even more strongly than the H2 receptor antagonists, and they act through hydrogen potassium ATP pathways, and the benefits are very similar to the H2 receptor antagonists, but they also have similar adverse effects as do the H2 receptor antagonists. Metoclopramide is now seldom used. It's an antagonist of dopamine 2 receptor subtype, It does promote esophageal clearance of fluids and enhances lower esophageal sphincter tone. But some of the adverse effects, which we may not be able to detect, especially in premature babies, but we do know that these are some of the effects that we see in older children and adults. We see tardive dyskinesia, irritability, drowsiness, apnea, dystonic reactions, and oculogyral crises. Erythromycin is also a commonly used pharmacologic therapy. Erythromycin is an antibiotic, but it also has this interesting effect on motilin receptors. That is an agonist for motilin receptors, and it promotes motility throughout the gastrointestinal tract by promoting migrating motor complexes. One of the problems with the erythromycin that has been seen, if you use it in antibiotic dosages, is pyloric stenosis. This again is a very seldom complication, and arrhythmias may be a very seldom complication, but you see more arrhythmias if you use erythromycin along with other antibiotics such as vancomycin. Most of the studies that have been reported looking at erythromycin as a promotility agent have not reported pyloric stenosis as a problem. Here are some etiologies of apparent improvement or lack of improvement after initiation of gastroesophageal reflux therapy. Improvement after initiation of therapy. There are symptoms correctly attributed to gastroesophageal reflux disease. The therapeutic intervention was successful. The therapy is efficacious in treating gastroesophageal reflux disease symptoms, or the therapeutic intervention was not successful owing to a lack of efficacy of the therapy, but improvement in the symptoms due to maturation caused by apparent response to therapy. So this is correctly attributing these symptoms improvement after initiation of therapy. And this is important to remember because we always have to think about the developmental aspects of these babies getting older and becoming more mature. And here, because of that, we see some symptoms that can be erroneously attributed to gastroesophageal reflux disease. The therapeutic intervention was not successful because the symptoms were not triggered by gastroesophageal reflux disease, but improvement in the symptoms due to maturation caused by the apparent response to therapy. The therapy may or may not be efficacious in treating true gastroesophageal reflux disease. If we see no improvement after initiation of therapy, the therapeutic intervention may not have been successful owing to the lack of efficacy of therapy, or that it may be erroneously attributed to gastroesophageal reflux disease if the therapeutic intervention was not successful because the symptoms were not triggered by gastroesophageal reflux disease. Okay, so let's talk about gastric motility next. We have electrical movements in the stomach that hormone. The gastrin is produced by some of the epithelial cells of the stomach. You have parasympathetic impulses from the vagus nerve, and then you have several hormones such as CCK, cholecystokinin, and secretin, which stimulate actually inhibit distension of the stomach. We have
بشكل مش طبيعي، وهم ليه ما يدوناش 16 اللي احنا متفقين عليها؟ يعني ايه؟
Okay, so here we have this
Professor Neu,
preterm baby again.
Professor Neu, excuse me, معلش.
And
We had around 2 minutes of loss of voice. You can repeat it, please, the last 2 slides. And then we will, after this lecture, for 5 minutes, we will have a break to arrange or to fix something in our internet.
Okay, so this just shows, can you hear me?
Yes, we can hear you now. Okay, we can hear you now.
Okay. So this slide shows the gastric motility, where you have electrical activity which causes constriction of the stomach at a rate of about 3 constrictions per minute. Okay, 3 major movements per minute. This is in the adult, okay? We don't have this same response in our preterm babies. It is much less well developed. But at the same time, we do have various factors that are important for stimulation of stomach movement. For example, distension. Simply putting food into the stomach will cause stomach movement and gastric motility. Hormones such as gastrin will stimulate stomach constriction. Parasympathetics from the vagus nerve stimulate stomach constriction. Then we have several factors which will actually inhibit stomach constriction. For example, cholecystokinin, secretin, duodenal distension, increased osmolarity, and decreased pH. These all inhibit gastric motility. There are certain kinds of food which will have effects on the stomach. Isotonic solutions will speed up gastric constriction, but fat will slow down gastric motility. Okay? Are you hearing me okay? Okay. So let's have a case. Here's a question. You're on call at 2 o'clock in the morning, and you've had a very hard day, and you're tired, and the nurse wakes you up and reports that this baby, who is being fed 2 milliliters of breast milk every 3 hours, is having 2 cc gastric residuals. What do you do?
Okay, Professor Joe, excuse me, we can have like 5 minutes best
Okay,
something,
so
and then rejoin
here are
again.
some options.
Okay.
And I would hope that you like the third option the best. But we have some real problems with the interpretation of gastric residuals. We don't know what is considered to be a significant gastric residual. Gastric residuals are usually done prior to the next feeding. And we have some problems with gastric residuals because every time a nurse does a gastric residual examination, she will pull back and create a negative vacuum, and that negative vacuum on the tube may actually exert a negative pressure on the epithelium of the stomach, and you could potentially be doing a small biopsy of the stomach every time that a gastric residual examination is done. We also have the problem where if you see a gastric residual that might look a little bit yellow or discolored, the nurse decides to just throw away that gastric residual. But this is a problem because the baby has been working very hard and has secreted acid and pepsin and various other enzymes to begin to digest that food. And so that gastric residual that is thrown away is actually the the result of something that that baby may have been working very hard to try to digest. So the question then is, should we actually be doing gastric residual studies in our preterm babies? There are several neonatal intensive care units that have stopped doing these routinely, but we have to have some kind of a study that helps us determine whether these gastric residual studies are useful or not. So we did a pilot study at the University of Florida, and this was published in the Journal of Perinatology in 2014. And here we see two groups, a check gastric residual group and a no check gastric residual group. We randomized babies to have gastric residuals checked or to not have them checked. And we see enteral intake 2 weeks and 3 weeks after birth was not that different. But here, when we get down to day of life when parenteral nutrition was discontinued and day of life when central access was discontinued, we start seeing some trends that look like they are different. And again, this is a pilot study with very small number of babies. We see that there seems to be this trend here that in the don't check gastric residual group here, we see approximately a 5 to 6 day less in the number of days of central line use than in the check gastric residual group. Here we see some of the potential clinical complications, and here we see this is liver disease, PNALD, sepsis, and necrotizing enterocolitis not being any different in the check gastric residual or the don't check gastric residual group. We have just completed a much larger study, and we are analyzing the data, but it looks like some of the results of the larger study will be very similar to this previous pilot study that was previously reported, but that is not yet published. We are still in the final stages of getting the data analyzed. So probably within the next couple of months, we will have that paper submitted for publication. What about the small intestine and the motility of the small intestine? Well, we have in the adult 12 of these peristaltic waves that are occurring per minute. We also have segmental constriction occurring. These are two different types of motility that we see in the small intestine. I'm not going to get into all of the parasympathetic, sympathetic mechanisms, but these are both very important for moving food forward and also grinding the food in the intestine. We have different neural innervations of the small intestine. And here we see we also have the external system, which involves sympathetic as well as sympathetic nerves. And the sympathetic will decrease motility, decrease secretions, and increase the constriction of sphincters, whereas the parasympathetic increase the motility and increase the secretions through acetylcholine. And it's important to remember that there are some anticholinergic drugs that we use very frequently in neonatal intensive care. And we forget that these may have these anticholinergic activities and actually decrease motility of the gastrointestinal tract. So for example, some of the eye drops that are being used when we do retinal examinations for preterm babies may actually have some of these effects and may actually decrease motility of the gastrointestinal tract when the ophthalmologist does an eye exam. We have other hormones that may decrease the constriction of sphincters, such as VIP. I mentioned this before, and these parasympathetic responses will also increase gastrin. Here are the different hormones that are involved. I'm not going to get into all of these in a lot of detail, but I think it's important to remember that all of these hormones are very important in the gastrointestinal tract for normal homeostasis. And these are stimulated by food in the gastrointestinal tract. Here is a study that was done by Lucas and colleagues back in the mid-1980s, and they looked at plasma gastrointestinal hormones in premature infants. And here we see 5 of these different hormones. And at the time of birth, we see these hormone levels. And 6 days later, if these babies were not fed, we see that the gastrointestinal hormone levels are about the same. But if we feed the babies, even if they're sick with RDS, we see a major increase in these 5 different hormones. So feeding is a major stimulus to these very important hormones that control the gastrointestinal tract. So we have this concept now that is called minimal enteral nutrition, and in the past, I know that many neonatal intensive care units were very afraid to enterally feed very low birth weight babies. But I think we're getting to have more and more data that shows that putting food into the gastrointestinal tract early in our preterm babies has many beneficial effects. So here we see at least 12 studies of what we call minimal enteral nutrition that show positive effects, such as improved feeding tolerance and growth, less need for phototherapy, decreased cholestasis, decreased osteopenia, and highly relevant to this lecture, gastrointestinal trophic hormone surges and improved motility, but no increase in complications, such as necrotizing enterocolitis. Here we see different regions of the gastrointestinal tract and some of the motility actions that are important in these different regions. So in the upper gastrointestinal tract, in the esophagus, peristalsis is very important. In the stomach, we have a combination of peristalsis, storage, and mixing, and that mixing is due to the grinding effects and the peristaltic effects of the stomach. In the small intestine, we have peristalsis and mixing, and in the colon, we have peristalsis, storage, and mixing. Now, I'd like to get back a little bit to erythromycin, and we have some babies who have feeding intolerance that is very difficult to try to treat. We've all taken care of babies who seem to get gastric residuals, large gastric residuals, or babies who have abdominal distension, and we take x-rays. We don't find any real problems in these babies, but we get very frustrated in that we are not able to move forward with our feedings. Well, it has been found that erythromycin may be helpful in this situation, but again, it should not be used routinely. This is from a study that was done by P.C. Ng from Hong Kong and reported in Neonatology in 2009. And what he did was look at several different studies, about 9 different studies, and he surmised from these 9 different studies that the current information favors the use of rescue rather than prophylactic erythromycin intermediate to high doses rather than low dose erythromycin, and that this medication should be administered intragastrically rather than intravenously. And that if we use oral erythromycin, it should be used cautiously and selectively in preterm infants with moderately severe functional GI dysmotility and in whom structural obstructive lesion has been excluded. So one way that I recommend using erythromycin is if you have tried several different things, such as trying prolonged feedings with a pump. So increasing the amount of time that you are providing a feeding to a baby, perhaps with a pump. 1 hour of pump feeding or 2 hours of pump feeding with 1 hour rest. If you tried something like that and that is not working, and positioning the baby in different ways and that is not working, I would suggest the use of erythromycin for 2 to 3 days. And if you do not get a benefit after 2 to 3 days in terms of improved gastrointestinal function, then I would stop it. If you do see a positive effect or a benefit, then keep it on for keep using it for about 2 weeks and then stop, because maturity of the baby probably has improved and the baby may be able to take over at that time. But do not keep that drug going indefinitely. So in terms of small intestinal motor function in preterm infants, some of the physiologic events that I showed you before, we have in the preterm infant some of these events that do not occur the same as they would in a term infant or in an older individual. We have absence of migrating motor complexes, prominence of clusters, absence of mature motor responses to feeding. And here are just some pictures of motility in the colon. And here we see that, again, we have mixing movements, and also we have some peristaltic movements in the colon. And again, as I mentioned before, the colon is also the storage organ. And here we have next the mechanism of defecation. And at the rectum and in the anus, we have some muscles that are very important. If you have a baby who has an imperforate anus, some of these muscles may never function during an individual's lifetime, but it's important that these muscles function normally, and in the preterm infant, it takes time for these to also develop their mature, the details of all the different maturational factors here and the physiologic factors. But again, it's important to remember that there are maturational responses that occur, and that we don't have to have this concept that a baby, a preterm baby, should pass meconium every single day or pass their stool every single day. In many babies, very preterm babies, we have a delay of meconium passage.
Professor Neu, we cannot hear you.
Using these routinely
Excuse me, please.
in most of
Professor
our preterm
Neu?
infants.
Excuse me, please.
So here is the
Professor Neu?
take-home message. The developing gastrointestinal tract is complex and is much more than an organ of digestion and absorption. The premature infant is capable of significant but limited digestion and absorption. Motility may be limiting, but all of
هو مش سامعني.
Hello, can you hear me?
Sorry, Professor Neu, do you hear me?
Yes.
Okay, can we take like 5 or 10 minutes just to fix our net and to have a better stability, because we had several times loss of your voice.
Okay, certainly. Please let me know when you're back on, okay?
Okay.
I'll see if I can do something on this end too.
Okay.
هناخد
Thank you.
10 minute break ونحاول يتظبط فيها الانترنت ونبدأ بعد كده.